who recommended to go ahead and start him on dialysis. And after starting, 2 hours later, he arrested. So the documentation indicates that bystander CPR was initiated. He was defibrillated by bystanders one time, and that at the time of fire arrival, he was also defibrillated, which is, I believe, what this rhythm is to indicate. He had pulses at the 4-minute mark with a blood pressure of 101/46, heart rate of 154, and end tidal of 31. They placed him on a monitor and noted what they called as VTAC with pulses. An iGel was placed on the first attempt. His vital signs remained present and for the most part stable, at least blood pressure wise. His heart rate started to decrease to 107, and they initiated transport approximately 11 minutes after initial patient contact. En route, they placed an IV. The iGel was removed, and they noted that it was removed because he was gagging and not tolerating the bag valve mask, so he was placed on a non-rebreather. And while he was en route, they started on a lidocaine drip. The documentation and the correspondence with the crews was that 200 milligrams was placed in a 500 milligram cc bag, and that the goal administration was 2 to 4 milligrams per minute. Continued to have stable vital signs besides his increase in his heart rate. And then at 7:28, they noted that he was in what I believe would be white complex, interpreted as VTAC, and I believe unstable, so that's why they shocked him. At 200 milligrams, per the crew, the patient apparently cried out after being shocked, so the subsequent doses of electrical cardioversion was with Versed. So this is the second shock by EMS, both fire and AMR. And then here's the third. So a total of 5 shocks from the initial decompensation. He arrived at the hospital with continued pulses of 113, blood pressure of 197/115, and breathing approximately 27 times a minute on a non-rebreather mask. And that the EMR documented that EMR, not AMR, documented that there was no amiodarone both on the ambulance as well as the fire crew's equipment, so they had to give him lidocaine, and that was the decision for why. In speaking with one of the crew members last night, it sounds like we are in the pre-hospital setting a shortage for a few months with amiodarone, and I don't know if there's anyone that can speak to that, confirm it or not. So in case review, we felt that the things that this crew, both fire and AMR had done, or EMS had done, was that they recognized that this was an unstable arrhythmia and they defibrillated and synchronized, cardioverted it appropriately. That amiodarone would be preferred, but due to our shortage of amiodarone, an alternative medication, lidocaine, would be indicated. Room for improvement, the dosing and the administration of lidocaine was not within our protocol. So review of the lidocaine protocol, as well as consideration for treating for possible hyperkalemia in a patient that's at dialysis or known end-stage renal disease in cardiac arrest. So for case follow-up, in the emergency room, he was noted to be unresponsive with an unorganized tachydysrhythmia. They felt that was most likely related to AFib with the white complex or white QRS. They did cardiovert him 3 subsequent times, several minutes after his arrival, which here's a couple 12 leads. And I believe this last one is when they stopped shocking him. He was RSI'd. He was started on amiodarone, calcium, magnesium, and sedation as he started to wake up after after controlling his dysrhythmia, and he underwent cooling with an icy cath. His initial troponin was elevated at 3.2. He went up to the cath lab shortly after the ER arrival, and they noted that he had extensive four-vessel disease with complete occlusion of the circumflex. Unfortunately, though, his lesions were not amenable to stenting, so he was to be considered for cardiac or CABG for bypass grafting. After leaving, which did not occur during his cath lab encounter, he went back to the ICU and was placed on an intra-aortic balloon pump for cardiogenic shock, and they noted that his EF was 35% and he had severe mitral regurgitation. He remained on the intra-aortic balloon pump. He was on a heparin drip. He was on lidocaine, amiodarone, and norepi drip. I have the amiodarone crossed out because throughout his entire encounter, which was approximately 10 days, he was on lidocaine the entire time and on and off amiodarone due to elevated liver functions. Throughout his course, he remained in and out of AFib with RVR. He was hypotensive. He was later found to have pneumonia, suspected to be aspiration related, in that he was reintubated due to respiratory failure and encephalopathic with worsening heart function, and never was stable enough to undergo CABG. His family thought that this was not the goals of care that he would want, so they placed him on comfort measures, extubated him, and he passed away shortly after extubation on hospital day 10. Oops. So I thought this was, or we all thought that this was a good chance to talk about lidocaine and its dosing. So lidocaine depresses the automaticity of the Purkinje fibers, raising the stimulation threshold in the ventricular muscle fibers, which means that the ventricles are less likely to fibrillate. It has very little effect on the atria, and it also can be used as a local anesthetic. So indications here is recurrent VFib, VTach, and white complex tachycardia. In speaking with one of the crews, I think that it may be a little bit confusing in that it's given for without pulses and with pulses if it's indicated with any of these rhythms. And it also can be given for IO needle administration for the pain of administering the IO meds. Contraindications to administering lidocaine include a low blood pressure, a low heart rate, sinus arrest, or second or third degree heart block. In precautions, we want to not use it if there's a supraventricular arrhythmia, and if the patient starts to seize while receiving this, we should also discontinue its use. Side effects include drowsiness, dizziness, disorientation, confusion, and potential seizures, as well as hypotension, and that if there's impaired metabolism such as liver failure or heart failure, then we would recommend a smaller or lower dose on the initial administration. Intoxicity is more likely in elderly, 1, because of metabolism, 2, because usually less medication can have the same effect than normal adult dosing. So dosing for adults is going to be 1.5 mg per kg IV IO, repeated for a max of 3 mg per kg. And speaking with Dr. Whitwer, the subsequent dose after the first dose, which we'll clarify in our protocol, is going to be 1 mg per kg. And then for pain management, it's 40 milligrams slow bolus. Anyone have any questions, concerns?
Jackie, you might mention that we don't have any orders. There's nowhere in our orders where we have a lidocaine drip.
Correct. There is no indication in the pre-hospital setting in our protocols to use lidocaine as an infusion. Now, if you're looking at any pharmacopoeia books, that might be an indication in the hospital, but not in the pre-hospital setting. So it is bolus given. In my experience, for cardiac arrest, we give it just as a push bolus. If you have a patient with a pulse, you may want to give it over 5 to 10 minutes. But I would say that regardless, my experience is just a bolus. Can any of the other docs on the meeting concur or give any other thoughts about administration, bolus versus slow push? Okay. And again, this is 1.5 mg per kg IV bolus for pulse or no pulse if indicated by rhythm.
And I think we want to look carefully. You know, it is not recommended to use lidocaine in supraventricular rhythms, and unfortunately, we have a supraventricular rhythm in this case.
And yes, and
this is an AFib RVR with wide complexes.
And I thought that that was one of the points I wanted to point out, that yes, we don't want to use it in supraventricular arrhythmias, and that it was continued in his hospital course due to his in the conjunction with his cardiology team.
Right.
All right. If nobody has any questions regarding case 1, we'll move on to case 2. So EMS was dispatched to a choking or ineffective breathing related to food to a 77-year-old female who they found unconscious and unresponsive. PPE was appropriate. They do document that they removed the HEPA filter and placed a surgical mask, but maintained 6 feet of distance from the patient. So I'm not sure if that's in regards to once the driver decided to get in and start transporting. Primary survey notes that she was unresponsive to painful stimuli. Her airway was obstructed and she was not protecting, and that she was pulseless. Initial vital signs are pulseless and apneic, but were assisted at 18 her ventilations. And her past medical history included coronary artery disease, status post CABG, as well as type 1 diabetes. The history provided by bystanders was that she was eating steak dinner with her family and that she started to choke. They started with abdominal thrusts, but shortly after initiating this, she became unconscious and they started bystander CPR. From patient contact at 1933, she was found to be asystolic. They placed an IO, they gave her epi and resumed CPR. End tidal noted to be elevated at 53. They placed a second line and gave her a second dose of epi on the next pulse check, as well as suctioning. It appears that they were unable to ventilate with a BVM, and they were also unable to place the iGel, so DL was used as well as gills, and a large chunk of steak was removed, and then the iGel was placed. And take note of the time. We have approximately 10 minutes from patient contact to iGel placement. She had a third dose of epinephrine given, and she sustained ROSC at 12 minutes after patient contact. Her initial heart rate was 60, no blood pressure was taken, and her SpO2 was 95% with an end tidal of 39. First 12 lead after ROSC is here, interpreted as atrial fibrillation without RVR. At that point, RSI was initiated with 100 of ketamine and 150 milligrams of succinylcholine. Unfortunately, though, she rested and started CPR again. So epinephrine was administered. At this point, she's almost 30 minutes from arrest with EMS arrival, and presumably longer given that her family initiated it. So medical control was contacted for pronouncement. It sounds like that they did get approval for pronouncement, but the person that called medical control went back to the patient and noted that she had regained ROSC again with a heart rate of 48, no blood pressure obtained, respiratory rate of 19, ventilated, and they initiated pacing for bradycardia. She was a little bit more stable in that they were able to get a blood pressure of 63/38, and they initiated transport. In reviewing the crew's documentation, they did wait a while to make sure that she did not arrest. So from ROSC to transport, it looks like it was 16 minutes. Unfortunately, though, shortly after starting transport, she arrested again. Another dose of epinephrine was given. They were able to get ROSC a minute after giving epi with this 12 lead, showing an irregular rhythm, presumably AFib with Y complex right bundle branch block. She had a heart rate of 80. Her end tidal was was 30, in that they continued to try to intubate her by doing delayed sequence intubation, giving her ketamine, but she was unable to get SpO2 above 94%. So this was aborted when an iGel was placed. Unfortunately, though, she again arrested prior to hospital arrival with CPR continued. So, in summary, for EMS care, compressions, peripheral access, meds, airway obstruction alleviated, and a supraglottic airway was placed. As areas for room for improvement, the team felt the medical program director's team wanted to know why she was not intubated when the Magellan laryngoscope was used initially. And they wanted to address why even bother with doing DSI or RSI in a patient in cardiac arrest with a GCS of 3. And then for additional is that with the goals of ACLS being compression, airway, and breathing, that in review of the reports written by the crews, it looks like it was about 10 minutes before iGel was placed, which was coinciding with when the airway obstruction was removed. So it seems like, although we did CPR quickly, that we want to make sure that we ensure that the airway's open and do what we can to alleviate that airway obstruction immediately to reoxygenate the patient. So for follow-up in the emergency room, they resumed CPR, but they called the code 5 minutes after her arrival due to her prolonged downtime and her very poor prognosis and continued cardiac arrest. As for our protocol review, I thought that we could talk a little bit about airway obstruction. We covered this a few months ago on my first one with you guys, but for partial obstruction, you're going to have them try to clear it themselves. Once it becomes a complete obstruction, you're going to do basically what happened here, where CPR and continuing to try to clear the airway. If they're unconscious, you can use a laryngoscope and McGill's. And if they're obstructed and not able to remove her foreign body or their foreign body, a consideration for cricothyrotomy would need to occur as long as the obstruction is above the cricothyroid membrane, and the option to right main stem or push potentially with an ET tube the food bolus below to right main stem if she has a obstruction at the cricothyroid membrane or below it. And then review of it's a good time to review cricothyrotomy placement. So you're going to be identifying the cricothyroid membrane with your non-dominant hand. You'll make a vertical incision, and then you'll make a horizontal incision through the cricothyroid membrane using your finger to dilate it, and then using a bougie to place it into the trachea, and then a ET tube or trach tube over the bougie. And remember that we do not do cricothyrotomies in pediatric patients. Dr. Whitwer, what's the age for pediatric patients for our EMS crews? Is it 12 or 8?
We say 10 to 12, but it's basically based on on size. If you have an adult-sized 12-year-old, I don't have any problem with that. It's a matter of finding. It's a matter of landmark and positioning and feeling comfortable with it. But by and large, figure that 12 is a good cutoff. But we've got some very large 12-year-olds out there nowadays.
That is true. All right, I think this is the last slide for case 2. Does anyone have any questions, concerns, issues they want to address? All right. Moving on to case 3. EMS was dispatched to a seizure of a 40-year-old male. Believed that it was some type of care center, not a private residence. Chief complaint upon arrival was that the patient was in respiratory arrest. PPE documented appears to be inadequate with a surgical mask, gloves, and eye protection, which we will become more clear as we move on with the case. Initial primary survey was noted that the patient was unresponsive. He did not, his airway was not open. He was clenching with his jaw, in that it appeared that he was clenching and biting, and that he did have a palpable pulse and there was no evidence of active bleeding. Initial vital signs documented are 79 for a heart rate, 175/71 for a blood pressure, and a respiratory rate, which I would assume was grossly inadequate, was 10, and then an SpO2 of 77%. His past medical history included COPD and asthma, and that per bystanders, which were family members, he was playing cards with them and had a seizure. The seizure stopped shortly after it started, in that he became unresponsive and apneic, therefore CPR was initiated, and that the family members had told EMS that he recently had a hole cut into his neck because of his breathing problems. So at patient contact at 12:24, as mentioned earlier, he had an SpO2 of 77%. They placed him on a non-rebreather. And I believe, if I remember correctly, and of course the crews that might be listening, that he was on CPAP and they took him off CPAP because of his unresponsiveness and placed him on a non-rebreather. He was suctioned, a peripheral IV was established, and that they attempted to bag valve mask ventilate him, but they were having difficulty in getting a seal. I believe that that was from his mouth, and that they noted that his jaw was clenched and that he was biting, and that even if they could get a seal, they were having obstruction problems past his teeth. His initial blood glucose was 165, and that they continued to assist ventilating him while attempting to replace his Shiley. He was a pretty obese gentleman, so at first they didn't recognize that he had a stoma, but when they lifted his neck up, they noted that there was a tracheostomy tube, and that coming from the tracheostomy tube, there were copious yellow mucus sputum, and so they attempted to replace the Shiley. Unfortunately, that was unsuccessful. But they continued to ventilate him. They were able to get his SATs up to 86%, and they attempted to place an ET tube through the stoma. Again, that was unsuccessful for the crews. And it looks like from the documentation that they provided, both fire and AMR came together for a decision to use sedation without paralysis to place in a supraglottic airway, because they anticipated that this patient would have difficulties if they paralyzed him for intubation, given his body habitus, his trach, and limited information about why it was placed in the first place. So ketamine was given. He was his airway was secured with an iGel-4. His end-tidal CO2 was noted to be 95%, but his SATs were 90%, and that he was sedated with Versed. 12-lead EKG was obtained afterwards, and they noted that his breath sounds were diminished with rhonchorous noises throughout. So they suctioned him and transported him, looks like approximately 23 minutes after patient contact and after airway securement. Subsequent vital signs: he's tachycardic at 113, blood pressure 123/65, and assisted ventilations at 24, now with an SpO2 of 93%. We gave him a second dose of Versed for sedation and arrived to the hospital. A couple of things here is that we want to be using pain and sedation meds, so fentanyl and Versed. So some of the good things that occurred with this case was that they moved him off CPAP and noted that it was contraindicated for his condition. They rapidly escalated his airway maneuvers from non-rebreather to bag valve mask with suction, in that I acknowledge that they may want to try bagging after connecting the bag valve mask to the stoma, because you may be able to ventilate through that, especially if you have a patient that's teeth are clenched. And then if you're going to place your bag valve mask on the tracheostomy bag valve mask adapter, that you want to remove the inner cannula if it's present. They were quick to get vital signs as well as the blood glucose, looking for reversible causes. And then they also recognized that this patient's airway could be very difficult, and that they preemptively decided how they were going to troubleshoot it and came up with a plan that they all could agree on and executed it, which worked out well for him in this situation. Areas for improvement. Our PPE with a surgical mask is not appropriate if we're doing any aerosolizing procedures, especially intubation and ventilation with a bag valve mask. Make sure that we document a HEPA filter. Check pupils. So make sure that his pupils are not pinpoint or asymmetric, and that this was a good opportunity to review trach care, which is what this section is going to cover next. And then pain intubation, post-intubation sedation should be pain and anxiolytic pain first treatment. In the emergency room for follow-up, he was intubated with ketamine and succinylcholine using video laryngoscopy, and ET tube size 8.0 was placed. During his hospital course, he was extubated on the following day. They thought that his respiratory arrest, acute on chronic, was related to an overdose on heroin, leading to his apnea and hypoxia. They did evaluate his head for etiology of a seizure-like activity, which was negative, and that during his course of 5 days, he had no further seizure-like activity. He was discharged with a diagnosis of respiratory arrest, acute on chronic, as well as heroin abuse and seizure disorder potential.
Jackie,
Yep.
did we get any? Did anybody give in any Narcan?
No.
And at least not on this. Now, and how old was this?
40.
Stoma? You said he.
Oh, that's
no,
actually
no,
a question. Yeah.
How old was his stoma? Because you had said that the history was, well, he's got, he had a quote hole in his neck placed some time ago. But I'm not, if this was a fully developed, fully healed trach, that's been there a while. So, and was there any attempt to pass a bushie down this thing?
None was documented, and as for the age of the tracheostomy, it doesn't appear that we were able to confirm how long it was placed. I only have a sentence saying that it was recently a hole was cut in his neck, so it doesn't. We don't know how long it's been there. So, and that's why I thought that this was a really good opportunity to talk about what is important when we talk about trach care and trach emergencies with everybody.
And also history. We have a history of COPD, et cetera, in a apparently young man. Do we have a history? Did he have narcotics, opiates at home? Is there a history of drug abuse that was elicited by the cruise?
Not that was reported, and it was only noted by urine drug screen on his hospital encounter, and knowing that EMS did not give him any opioids, that they presumed that he was into either heroin or other prescription narcotics.
Right. Okay.
Yeah. So when I queried our protocol, the only area that came up were these two areas for tracheostomy. So suctioning a tracheostomy and who's allowed to do it, as well as the CPAP is contraindicated relatively for intolerant tracheostomy if lack the adapter. So room for some discussion, especially because this is a condition that we don't see as often, but we are seeing more and more as more of our patients are going home or to assisted living or nursing homes with a tracheostomy in place. So there are multiple different types of tracheostomies. The ones I listed here are Jackson, Bavona, and Shiley. Shiley is what we use predominantly in this area according to our respiratory therapists at Peace Health. Bavona is something that is more of a newer item, and the only reason why I mention it is because you don't have to deflate the cuff with a Bavona, but we really aren't using it in this system, so don't worry about it. So we're going to talk a little bit about, so you have the flange on the left-hand side with the outer cannula and the cuff. The size indicator is going to be on the flange, and that there might be a pilot balloon. Pilot balloon would not allow them to talk. And so they can have a pilot balloon, but if it's deflated, they'll be able to talk, just to be aware of that. There's an obturator, the image on the middle there, that helps in keeping the form and shape as the tracheostomy is placed or exchanged and is removed after it's placed. And then there's the inner cannula on the right-hand side. Good opportunity to talk about who gets them. So anybody that might be difficult to wean off the ventilator, so our chronic respiratory failure patients, any major trauma to the neck or face would potentially indicate that a tracheostomy needs to be placed. As you can see, the image on the right upper hand side is an example of that. Any upper airway edema that is acute or potentially chronic, but anyone that we're worried that their airway is going to be further complicated by further edema, any devastating neurological injuries, supraglottic or subglottic pathology, congenital anomalies, foreign bodies that are above the cricothyroid membrane or the trachea for the tracheostomy placement, and then for prophylaxis or severe sleep apnea. Prophylaxis might include like botulism and toxicity. So in summary on this, the three reasons why a patient gets tracheostomy is to bypass obstructed upper airways, either from short-term foreign body or from cancer, or to remove secretions from the airway, or for easily and safely delivering oxygen to the patient. So tracheostomy questions that we should be asking when we make patient contact both in the pre-hospital and hospital setting is, why was it placed? If it was placed, so the most important for me when I am asking is that, do they have a patent upper airway? Is this post-cancer, post-radiation? Did they have a laryngectomy where that upper part of their airway is removed and that we don't have an option to put an iGel or to put an ET tube above? How long has it been in place? It takes about 7 days for it to mature after it's placed. If they have stoma maturation sutures, that it may be as short as 3 days. But the reason why it's important is that if you try to remove it or you try to replace it when it's in its early phases, that you run the risk of third spacing air into the neck, inability to recannulate, due to a false passage, bleeding emergencies, or respiratory arrest because you can't replace it. So really important for us to know how long this trach stoma has been in place, what type and what size. It sounds like in the documentation with this crew that we have Shileys on hand in the ambulance. Is that true?
Yes.
Okay. So what type and what size would be really helpful for the hospital, because especially if you're having any problems ventilating or replacing, we want to have it available to place as soon as you arrive. So that is important. If you're having issues with the trach and you need us to be ready to help out with it, is to let us know so that we can get that for your arrival. And then when it was last replaced, was there any issues? And then lastly, how to ventilate, which we'll talk about briefly here. So a couple images of the size and the name of the tracheostomy on the right-hand side. So most commonly, obstructions are going to be mucus or secretions. You want to make sure you have all your backup equipment. They should be on the monitor because you may develop arrhythmias from suctioning them, and you also want them to be on a SpO2 and end-tidal. You're going to place them in a position that facilitates for you to suction them. If they're breathing on their own, you want them to try to expel their secretion by potentially coughing. And that if they are not doing an adequate job on their own, then you may need to use a catheter and vacuum system. You don't want to use a suction catheter that is the same size as the trachea or the tracheostomy. You want to use about half the diameter. You can use a little bit of normal saline to decrease the viscosity, and suctioning by placing the suction catheter, soft suction catheter, down until you hit basically a soft resistance, which would represent the carina, and then suctioning on the way out, doing no more than 3 times continuously and no more than 10 seconds on each try. If you still are finding that you're not able to suction, and the next option you can do is to use a bougie to potentially break up any kind of solid dried secretions that are obstructing the tracheostomy or stuck in the trachea. All right. If suctioning is not getting you anywhere and it's pretty clear that you need to escalate, if the tracheostomy stoma is greater than 7 days, then we can talk about this slide. If it's less than 7 days and they have not had a laryngectomy, you can place an ET tube or an i-gel, because removing that tracheostomy is fraught with potential issues. So if it's greater than 7 days, you want to put the patient into a position such as a semi-recumbent, so semi-laying back with their neck partially flexed. You want to put the obturator back in to position the tracheostomy through the stoma, and you're inserting at approximately a 90-degree angle to the neck. You're pushing downwards, and the flanges of the tracheostomy, the Shiley, should be flush to the neck. Once it's placed and seated, you'll remove the obturator and you'll insert the hollow internal cannula, and you'll inflate the cuff, and you'll confirm placement and secure it. So one of the points that I didn't mention on the review of this case is that when they placed the i-gel from above, and I'm not sure if they left the tracheostomy, the Shiley, in place. If you do leave the Shiley in place, you have to deflate the cuff in order to ventilate from above. So potentially this crew had left the Shiley out, and if that's the case, it's out, then you want to either place a finger or some kind of occlusive dressing, probably more of a finger, over the stoma so that you don't lose pressure as you're ventilating from above. If the Shiley is in place and you're ventilating from above, a cuffed tube on the Shiley would prevent you from adequately ventilating this patient. Any questions, concerns before moving on to the next case?
Jackie, there was a comment in the chat section on that.
Yeah. Should I switch over to that screen, or would you mind reading it?
No, I'll do it. Yeah, sure. So the medic involved with the care of this patient said patient in this case did not have a trach. He had recently had the trach removed, and the stoma itself was partially healed.
Okay. So helpful in a couple of ways. Helpful that it's been removed, and that trying to replace it would mean that you're not waiting for it to mature because they're waiting for it to seal, or just leaving the stoma in there as an option for them to potentially reinsert a Shiley, and that it speaks to why placing the i-gel allowed to ventilate because there's no need to deflate the cuff. All right. Thanks for the update to the crew that put in that comment. And if that's no further questions, we'll move on to case 4. So case 4, EMS was dispatched to an unconscious party of an 85-year-old female. Chief complaint was that she had a syncopal episode. PPE was appropriate. Primary survey noted that she was awake and alert, her airways open, and that she had a pulse, but she was pale and she was diaphoretic. Vital signs obtained 2 minutes after patient contact were significant for a heart rate of 80, or actually not significant, but present for a heart rate of 80, blood pressure 147/118, respiratory rate of 16, GCS of 15, and an SpO2 of 99%, and that she had a past medical history of myasthenia gravis. According to both the patient and potentially the husband, the patient was trying to get up to use the bathroom but had syncopated at the foot of her bed. It sounds like she crawled in to use the restroom despite passing out before getting there, and she again passed out while she was using the toilet, and apparently she had passed out up to 5 times prior to EMS initiation. They had noted that she had a Holter monitor and that she'd already returned it, but no known arrhythmias noted from the Holter monitor at that time of patient contact. They were able to get a 4 lead on her about 4 minutes after patient contact, and they document this rhythm. I guess we'll talk a little bit about this rhythm, but there's some 12 leads that show it a little better. So you can see that she has 4 to 6 probably perfusing beats in regards to her ventricles, and then a lot of just P waves on that bottom image. Next set of vital signs, she remains pretty stable despite that rhythm, although they noted that when they attempted to get her up onto the bed, she had passed out again, and that she had a radial pulse that was present, then was not palpable for about 4 seconds, and then returned, and then would again be non-palpable. They noted that she was breathing throughout this entire syncopal episode and her cardiac activity, and that she continued to have these episodes about 7 times throughout the remainder of the call for them. They placed an IV, and they got a 12 lead, interpreted as first-degree heart block with ventricular pause by the crews, kind of showing more of this same as we saw in the 4 lead. Narrow complex, first degree, then this ventricular arrest or ventricular pause, and then the resumption of what we believe is to be a pacemaker of junctional etiology due to narrow complex, and then short resumption of her underlying rhythm. I actually had a couple other people weigh in on these 12 leads that I might wait till the next one to talk about. Her blood glucose was normal. They left for hospital transport to Salmon Creek 13 minutes after patient contact, and repeated her 12 lead here. So I think maybe I'll just talk about the 12 lead interpretation afterwards. She remains stable, at least in regards to the blood pressures that they obtained, and the things that, after review of this case, that I thought the crews did really well about is that they identified that the rhythm present was an issue. They did multiple 12 leads that allowed us to have multiple interpretations of what her underlying issues were. They placed an IV, and they didn't spend a particularly long time on scene. Places where this crew could improve would be including placing pacemaker pads given the ventricular standstill, and then the consideration for atropine and or epi, and maybe that might have been more in relation to rhythm identification. At Legacy Salmon Creek, she had a repeat 12 lead done that showed this first degree with a left bundle and then this ventricular arrest. as seen by the pre-hospital 12 lead, cardiology was consulted. They felt that they were unable to place an emergent transvenous pacemaker, so they asked to transfer her to Peace Health. She remained stable hemodynamically and arrhythmia-wise en route to the hospital to Peace Health, as well as in the emergency room. She went to the cath lab emergently that night for an emergency transvenous pacemaker, and then they placed a permanent pacemaker on hospital day 1 the following day. She was discharged on hospital day 2 with an uncomplicated course, just besides her pacemaker failure, which is her underlying pacemaker, her heart. So talking briefly about rhythm identification in heart blocks. So first degree heart block, it's when the PR interval is greater than 0.20 seconds. All P waves conduct to the ventricles, with an image noted on the right-hand side just as an example. There's 2 types of second degree heart block, type 1 and type 2. Type 1 is often referred to as Wenckebach, and that's when the PR interval gets progressively longer until a non-conducted P wave occurs. The RR interval of the pause is less than 2 of the preceding RR intervals, and then the RR interval after the pause is going to be greater than the RR interval before the shortening, if that makes sense. And then type 2 second degree heart block is when the PR intervals are constant until a non-conducted P wave occurs. This must be 2 consecutive constant intervals to diagnose it as second degree type 2. And then third degree heart block, which is a complete heart block. It's usually complete AV dissociation. If the QRSs are narrow, we think that the escape focus is going to be at her or at their junctional or above the pacemaker focus. And then if the QRS is wide, we feel that the escape focus is going to be ventricular. And then there's also AV dissociation, which includes third degree heart block, but there are other types of conditions that lead to AV dissociation, and it can be incomplete or complete. And the 3 main categories for AV dissociation is going to be slowing of the primary pacemaker, so an escape rhythm, acceleration of the subsidiary pacemaker or usurpation, and then second or third degree heart block, which is what we typically think of when we think of heart block as this AV dissociation, and that's the 3rd category. As for this PowerPoint, I ended up consulting outside of our system for some identification on rhythm, because there was disagreement or different interpretations of this 12 lead in physician level. There was third degree heart block interpretation of that previous 12 lead, as well as second degree type 2. And I spoke with Dr. Smith. If any of you guys follow his EKG blog, Dr. Smith's EKG blog, which is excellent and oftentimes a little bit higher level, but if you really are looking to up your cardiology interpretation and understanding, it's a great free online access. And he works with a associate editor, Ken Grauer, which is another well-known, I believe, an emergency room doctor based out of Florida that has written a couple books on EKG interpretation. And the 4 slides following this slide are Dr. Grauer's interpretation of all 4 12 leads, in case anyone is interested in reading a very involved discussion of the interpretation of that. I'm going to save you guys from that in this PowerPoint presentation. So bottom line is that this patient, no matter how you interpret it as second or third degree heart block, has severe AV nodal disease and needs a pacemaker. They could benefit from a trial of atropine and or epinephrine, and that we should have pacer pads on them. And then this, where is my, there it is. And that for our Southwest region protocols is that We do indicate that if they're bradycardic, which when you have the sinus or the ventricular arrest, the patient is bradycardic, and that our protocols indicate that we could try 0.5 milligrams of IV atropine up to 3 milligrams, and that if there's no response to that, then epinephrine infusion could be considered. And that's a plug for Dr. Smith's EKG blog. And that is the end of my case reviews for you guys. Do you have any questions?
So Jackie, comment on the last particular case was that the defib pads were actually placed on the patient. Maybe didn't show up in the documentation somewhere, but yeah, they were placed. Awesome.
That's a good care. A couple things I wanted to mention. That last case was a self referral, probably maybe not necessarily looking to be in case reviews, but wanted to know outcome of this patient. So please continue that if you have a patient that's interesting or that you think your colleagues could benefit, or you just want some follow-up and you want me to help in getting that follow-up, send an email out to me on the email listed on this page. And then a couple other things here. I've worked the last 4 days, including last night, and we are seeing a rise in COVID patients, anywhere from 3 to 5 patients during my 8-hour shift that have been diagnosed with COVID. So that's obviously minus the rest of the 24 hours. So really make sure that you're using proper PPE. At minimum, we should be using eye protection, surgical mask, gloves, and that anyone with a aerosolizing procedure, we should be escalating to a HEPA filter just to keep us all safe. In that, I know that this has been months in the process and it's been laborious and it's such a pain to be wearing a mask and potentially even breathe with them as the temperatures get hotter, but you'll need to please do your due diligence to make sure that you're keeping yourself safe, your colleagues safe, and your family members and loved ones safe at home too. All right, if there are no other questions right now, I'm done with discussion. And if you do end up having any questions about this or anything in the future, reach out to me by my email.
Great. Well, thanks, Jackie. And thank everyone out there for showing up today. We'll do it, when we decide, 4th Tuesday of the month to do case reviews. So same time next month.
Fantastic. And feedback, if anybody hates the color purple or has any other concerns, let me know so how I can change it to be better for you guys.
All right. Well, thanks everybody for coming. Thanks, Jackie.
Thank you.